Carol, and welcome everyone to our session to talk about dispelling health disparities. My name is Ricky Fairley, and I'm the CEO of Touch, the Black Breast Cancer Alliance. And I have a wonderful panel of brilliant people today to talk about stopping the madness. And I call it the madness. COVID has brought to life what I've known my whole life about, health disparities, but now it's on the table and we have an opportunity to really address some of these issues head on. And I have three amazing speakers, and I'm going to introduce them right now, and then we will get into, hopefully, a very rigorous discussion about how we can stop the madness. So first, and I will introduce you first, Dr. Brawley, since you're surrounded by beautiful women. So we have Dr. Brawley, and he's a globally recognized expert in cancer prevention and control. He's worked to reduce overscreening of medical conditions, which has revolutionized patient treatment by increasing quality of life and reducing health disparities. He's currently the Bloomberg Distinguished Professor of Oncology and Epidemiology at Johns Hopkins University. And he's held numerous positions. He was actually the Chief Medical and Scientific Officer and Executive VP of the American Cancer Society for 2017 and 18. So welcome, Dr. Brawley. And then we have my breasty sister, Jamil Rivers. I love you, Jamil. She's the founder of the Chrysalis Initiative, and her foundation was really born from her dealing with her illness of being diagnosed with metastatic breast cancer at age 39. She really is in the fight to help other women survive metastatic breast cancer. She's also the board president of Mediviver, a young advocate alum for LBBC, a board member of LBBC Living Beyond Breast Cancer, and the advisory chair of Knowledge is Power, a great forum for Black women that LBBC puts on every year. And Dr. Lisa, who's been in this fight to really on triple negative. She's my triple negative breast cancer hero, Shiro. But she's a surgical oncologist with a practice dedicated to breast cancer management. She oversees the breast program for the Weill Cornell Medicine New York Presbyterian Hospital Network. She previously worked at the Henry Ford Health System, and she has done years of research all over the world to fight triple negative breast cancer, which I totally appreciate as a survivor. So welcome, everyone. You guys are awesome. And so I'm going to just throw out some facts, and we'll get into a discussion about the health disparities I see in three disease states. So, and these are some recent numbers that I kind of just pulled. An article from JAMA in January identified that Black women with breast cancer have a 71% higher risk of death. A recent study done by MSK found that Black women were 2 times more likely to have cardiac side effects than white women with breast cancer. A new study that was just released on June 4th from Mount Sinai Health System, funded by NIH, said that Black women were nearly 6 times more likely to develop distant tumors than white women. So researchers found that Black women have a much higher risk of having their cancer spread to their other parts of their body. And we know the fact that, we have a 40% higher mortality rate, which in some states is way higher. In the southern states, it's in the 60s, right? The all-cause mortality of Black ovarian cancer patients is 1.3 times higher compared to white women, even when access to care is equal. With endometrial cancer, it's the most common gynecological cancer and is diagnosed in 1 in 37 women in the United States. Black women with this cancer have a 90% higher 5-year mortality risk compared to white women. So these numbers are atrocious for these diseases. They're atrocious. So I would love to talk to you guys about how we can tackle these numbers and what are some possibilities for addressing what's going on in these cancers for Black women. Dr. Lisa, want to start?
Okay. So thanks so much, Ricky, a very kind introduction. And I'm more than happy to make a few comments about my own perspectives on breast cancer, on disparities. And I think these perspectives are relevant to the facts that you just laid out there so eloquently. So again, my name is Lisa Newman. I'm such an honor to be here, and I am a surgical breast oncologist. And for most of my career, I have had a special research interest on the disproportionate impact of breast cancer on Black women. And this research interest has actually evolved into an international research program that involves several hospitals in Africa, where we not only help to build capacity by providing clinical services and educational training programs, but we've also been conducting exciting research that has been studying the genetics of African ancestry and how the DNA of our African ancestry influences the pattern of breast cancer and the types of breast cancer that we're likely to develop. And this correlation between ancestry and breast cancer is something that's actually been well defined and not documented for several other groups. For example, Ashkenazi Jews and understanding the risk of carrying founder mutations in the BRCA genes, but for a whole bunch of reasons, this research has really lagged for African ancestry populations. And breast cancer is actually a perfect example of the multifactorial explanation for health outcome disparities. Now, as I mentioned, my own research does focus on looking at the genetic underpinnings of breast cancer disparities, but as a researcher and as a clinician whose career has involved the diverse patient populations of downtown Detroit and Flint in Michigan, Brooklyn, New York, Houston, Texas, and now across the several low and middle income countries of sub-Saharan Africa, I'm also acutely aware of how access to care and systemic racism play a huge and dominant role in public health. In disparities research conferences, the question often arises regarding whether race has any genetic meaning at all, or is it simply a socio-political construct? Now, the answer, of course, is that race is both. The genetics of race, or what I actually prefer to call genetic ancestry, and the concept of race as a socio-political label are not mutually exclusive, and aspects of both actually do influence our health. Everyone's familiar with these wildly popular commercially available products that allow us to study our geographically defined heritage. We provide a saliva specimen that's used for DNA extraction, and then that DNA is analyzed. We get a report back regarding how much European, how much African, or how much Asian background an individual has. Well, the research that I and that many others have conducted very clearly demonstrates that some of these ancestral DNA patterns are also linked to specific health conditions, including cancer risk. These genetics don't completely define our health and cancer risk, but they definitely contribute. On the other hand, as we've all learned from the horrific experiences with COVID, as Ricky mentioned, and its disproportionate impact on African Americans, systemic racism is pervasive throughout our healthcare system. Residential racial segregation continues to exist, and with redlining, discriminatory banking practices, these have all resulted in several generations of African American families that have essentially been trapped in urban neighborhoods that feature food deserts, nutritional insecurity, poor public school systems, excessive population density, diminished access to broadband, high-speed internet, and environmental exposures like the water crisis. And so very clearly how we self-identify, but also how society labels us, influences how we live, where we live, and these social determinants impact our health. Now, these social determinants of health affect African Americans across all socioeconomic strata. Systemic racism results in Blacks having fewer educational and professional opportunities, and the inadequate diversity that we therefore see in the healthcare workforce results in Black patients, regardless of their affluence, being treated differently by our healthcare system. There's abundant data demonstrating that African American breast cancer patients are less likely to be offered reconstruction following mastectomy. We are less likely to receive necessary radiation after a lumpectomy, and Black patients with any type of cancer are less likely to be offered the opportunity to participate in a clinical trial. And now in the context of the COVID pandemic, it's more important than ever that we work collaboratively to achieve health equity. Communities of color have been hit especially hard by the COVID recession, and we're recovering from it much more slowly. We're just now starting to witness the impact of the pandemic on worsening breast cancer disparities. The higher jobless rates in communities of color means disproportionate high losses of employment-based insurance for those individuals as well as for their families. And in my own healthcare system in New York, we're already seeing a worsening of breast cancer disparities regarding stage distribution that already existed pre-COVID. During the COVID surge, we of course had to place our mammography screening programs and clinics on hiatus so that we could divert care to COVID patients and support shelter-in-place mandates. Now that we've opened back up, it's mainly the privately insured and affluent patients that are resuming healthcare practices and women of color that are disproportionately disadvantaged socioeconomically, have other financial priorities, and they're placing their breast cancer screening on the back burner. The NCI projects that by the end of this decade, we're going to see in excess 10 million deaths from colorectal cancer and from breast cancer. Unless we work with intentionality and laser focus, we can predict that communities of color are going to account disproportionately for a high volume of these excess deaths. But I am confident that by working collaboratively, we can overcome the systemic racism causes of breast cancer disparities that have been magnified by COVID. And we've also seen examples of these collaborations. We've seen powerful partnerships between breast cancer advocates and public health specialists to disseminate information regarding COVID vaccination programs and to get patients back into routine healthcare management. We can make it work. By working with our hospital leadership, we can make sure that our disparities research programs and community outreach programs are protected. And by working with policymakers, we can support Medicaid expansion programs that are now more important than ever in supporting socioeconomically disadvantaged patients and our safety net hospitals that have been devastated by the cost of COVID care. So there's definitely a lot to do, and Ricky, you laid it out there, but as evidenced by this conference and all the enthusiasm for this conference, we clearly have a motivated team to get this job done. So thank you again for your time.
I think we should just drop the mic. Okay. I think you hit on everything, Dr. Lisa. I so appreciate your comments. I think you hit on so many things about, disparities, but also the genetic ancestry of Black women, and so many factors are, not working in our favor. Dr. Brawley, I feel like sometimes Black women are often blamed for our situation in breast cancer. That we didn't do something that we could have done something to prevent our cancers. How do you feel about that? And how can we address that?
Yeah, well, first off, it's always a pleasure to be on a panel with Lisa, and Ms. Rivers, it's good to see you. I would say that there are disparities, and it starts with risk reduction or prevention. It goes all the way through screening and all the way through treatment. And I would point out some of the things that we can do with what we currently have. For example, you quoted some statistics. I would point out that there are 6 states in the United States where Black and white women have virtually the same death rate from breast cancer. That implies that there's something that can be done with what we currently have in order to lower the death rate for Black women. And it's not being done all over the country. I'd also turn that around, by the way, and point out that there are 12 states in the United States where white women have a risk of breast cancer death that is higher than Black women in Massachusetts. You're better off being a Black woman in Massachusetts than a white woman in Oklahoma.
And what are those states like Wisconsin, Idaho,
I can't give you the 12 states off the top of my head. The 6 states where Blacks and whites have very similar death rates tend to be up in the northeastern United States. And people in the Northeast, be they white or Black, tend to do much better than people in the south of the United States.
Yes.
Which indicates that there are problems in getting people health care. And unfortunately, health care is always thought of as screening and treatment. We need to think of health care all the way back to risk reduction or prevention. I don't blame a 50-year-old Black woman because she gained weight from birth until her teen years faster than the average white woman in the United States. But that is a risk factor for breast cancer. I don't blame Black women because they disproportionately don't breastfeed, but that is a risk factor for breast cancer. I don't blame Black women because 60% of them are obese or overweight, but that is a risk factor for breast cancer. If you take the race out of it, go to Scotland. A lot of my studies are done in Scotland. Obese women in Scotland have a higher risk of breast cancer and some of the more aggressive types of breast cancer compared to non-obese women. Women who don't breastfeed have a higher risk of estrogen receptor negative or triple negative breast cancer compared to women who don't. It doesn't mean that every woman who gets triple negative breast cancer is obese. No, not at all. It just means that it's just like it doesn't mean that everyone who smokes cigarettes is going to get lung cancer. Yeah, but these are risk factors. Some of them are actually socio-political and caused by poverty and caused by racism. The lack of fruits and vegetables in the inner city caused by the redlining that Lisa Newman talked about is directly related to some of the obesity. Some of the mental anguish and torment that society puts people through causes people to eat more, and that causes obesity. And so we can, by getting people access to a number of things, lower the death rate. What Lisa says is all very true. You can't really change genetics, but there are some things that we can do that will lower the disparity. And I will point out that you talk about Memorial Sloan Kettering. Very interesting paper from Memorial Sloan Kettering that's also out there. Black women and white women who are treated at Memorial Sloan Kettering for breast cancer have very similar death rates, very, very similar risk of death. Not exactly the same, but much better than in many places. And so we need to figure out how to get adequate, high quality care. It starts with risk reduction, counseling of young mothers about what they feed their babies to prevent the baby from having breast cancer 60 years later, to adequate high quality screening. And some of the advocacy for screening is actually harming the problem because some of the we need to tell women get into a program of regular high quality screening. We so frequently encourage them to get into this one-off, get a mammogram thing. That's harmful. And then we need to think about adequate diagnostics and adequate treatment. I won't hold the floor too much longer, but one of my favorite studies that looked at inadequate treatment, I'm going to go to colorectal cancer right now. It noted that even I thought Blacks with colorectal cancer must have more aggressive disease because they're more likely to relapse. If you look at Blacks who are stage 2 colorectal cancer after surgery and whites who are stage 3, there's about equal relapse rate. So it's the stage 2 must have more aggressive disease, right? Well, in the California registry, they were able to look at Blacks who were treated and found out that Blacks are treated in generally only about 15% of all the hospitals that treat cancer in California. And in those hospitals, the pathologists usually resected out about 6 lymph nodes in staging the patient after surgery. And there are a whole bunch of Blacks who were stage 2 because they had zero cancer, they had 0 lymph nodes with cancer. The whites, on average in California, had 18 lymph nodes dissected out. And there are a lot of whites who were stage 3 because one of those 18 lymph nodes had cancer in it. The whites were much better staged than the Blacks, it turns out. And that's why we had stage 2 Blacks relapsing when stage 3 whites did not. They went a little further in this study. It turns out The Blacks tend to be treated in hospitals where the pathologist had 6 cases to deal with a day. The whites in hospitals where the patients had, or the pathologists had 1 or 2 cases to deal with a day. It's not that the pathologists were racist, it's that the pathologists who take care of Black people are in hospitals where they are overworked. This is an example of a disparity in treatment and a disparity in staging, and it leads to us having crazy ideas like dark skin makes people have more aggressive cancer. So we need to, I'll finish by saying we need to focus on how to get adequate, high quality care from prevention and risk reduction all the way through screening, diagnosis, and treatment. And it doesn't exist in any of those 4 areas globally across the country.
Thank you. Thank you for that. Jamil.
I think a lot of different interesting aspects were covered as far as just social determinants of health, access to care, different challenges. But I really think, and maybe this is just from my work and also from a simplistic perspective, I think that in aggregate, the studies show and the evidence shows that really the biggest contributor to these disparities is racism. And I think if we acknowledge that, we could really be dynamic in disrupting the disparities that we see in cancer care when it comes to Black people. So if we acknowledge that racism is the biggest contributor, and yes, we understand the societal contributing factors as far as social determinants of health and access and social economic income and all of that. But when all of that is the same, what is the common denominator a lot of times when we're talking vary by state, rural, community, affluent, academic, Northeastern, NCI, NCCN centers? The common denominator that we find is that it is racism in the healthcare setting. If you have HCPs, healthcare professionals, that are not able to even value Black life or see the value in this Black person receiving care or understanding or even recognizing this individual's humanity, that person is going to receive substandard care. So I think acknowledging initially that, yes, this is a incessant problem. We have seen this with even just the COVID pandemic, that in order to really be dynamic, I mean, I know that there are some practical solutions, but to me, it's almost as if we're trying to make makeshift options for a ship that's already sinking. So in order to steer it on the right course, acknowledge that racism is the biggest contributor in the care setting, knowing that sometimes there are structural issues, sometimes there are social economic issues and social determinants of health, but actually White people have those same challenges, as Dr. Brawley said. So when we're talking about comprehensive care, we find that, even in Medicaid, those disparities are eliminated if we ensure that the same standard of care that White people get, Black people should get to. And so if we find that there is that hindrance where we have professionals in the care setting, that are not able to, not allow their bias to inform their decisions, or to allow that racism to hinder their ability to provide that standard of care to Black people, there has to be checks and balances in place. What is that scorecard? What is that compliance, that accreditation to say that HCPs just don't have the autonomy to provide substandard care to Black women? So we are familiar with those studies that show that even, Black women are not receiving genetic or genomic testing at the same levels of their white counterparts. They're not, 1 in 4 are HER2 positive and not receiving standard of care of Herceptin. Those are, a lot of the time, it's not just neglect, it's not just circumstantial. It is due to a breakdown in that accountability to ensure that Black people can receive standard of care. I think we're going to be, I call it muddy waters, where we're going to be constantly in this whirlpool of saying, oh, it's this, it's that, it's this, unless we really step up and have that accountability within, some teeth and accountability within the care system, so that Black people, when they seek out care, that they receive that same standard of care, that it's not, that they can receive substandard care and it's just okay. There has to be accountability there. And I think that we would see outcomes steadily improve if that is its standard, because we know what the roadmap is. We know what that checklist is. We know what that comprehensive cancer care should be that white people benefit from with privilege. And it's, just something that a lot of times Black people do not benefit from. So ensuring that racism is not a hindrance to Black people receiving quality standard of care. And I think once that's in place, we would see a lot of these other challenges kind of fall to the wayside. I mean, we're always going to have those issues where, access and social determinants of health, but we're finding the same disparities in affluent Black people. So it's like a weathering, it's a flaw in the diamond. It's a chip in the paint, meaning that there's a procedure that's overlooked. There's a clinical trial that's not offered. There's a treatment that's not provided. It's just not that full scope and all hands on deck for Black people the way that it is with whites. And until we actually have that accountability in place, we're going to constantly have these problems. So I think having that accountability built in to our health systems to ensure that patients of color are not victim to bias informing, the decisions of their care team or the access to care or treatments that they're being offered. That's really when we're going to see, these disparities disappear.
Yeah, thank you, Jamil. And, I love that you brought up racism. I often see even privilege as part of the problem. So, many doctors will say, well, I'm not racist. I take care of my Black patients equally as my white patients, but they do things because they're privileged. And I'll give you an example. At my own oncologist office, I asked one of my doctor is actually Hispanic, but I asked a white doctor, how often do you recommend clinical trials to your Black patients? And with the best intention, with the best of intentions, with the best, trying to be caring, he said, well, frankly, Ricky, I don't offer clinical trials to my Black patients because I feel like I've gained their trust and I will scare them away. And I won't be able to care for them because they'll get no treatment if I offer them a clinical trial because they'll stop trusting me. So where does that come from? Does that come from, is that racism? What is that? I mean, I think
it's bias. It really is bias.
It's
right.
bias.
That's informing the care that now that patient is receiving. So those assumptions informing the decisions to say, you know what, because of the highlights in her hair, I don't think she's going to go to that clinical trial. Or,
right.
You know what, I'm just not even going to bother her with that. She's going to be non-compliant.
She's a single mom. She's got 3 kids. How's she going to do?
I would disagree with you a little bit there. I've been there this morning, as a matter of fact, seeing patients. I would say, Ms. Farrelly, that doc really ought to try to discuss with every patient the clinical trial and try to come up with a way of showing or saying that this is part of good care. But you indicated a doc who actually cares about their patients and is concerned about their patients. And that's something that I would encourage. Those are behaviors that I would foster. Now that being said, I have come to the conclusion in discussion with white and Black patients that maybe going on to the clinical trial is not in their best interest because they have transportation issues and they're not going to be able to make the added number of appointments that going on the clinical trial would take. The issue here for me is something should be discussed with the patient, and the doctor and the patient, more the patient than the doctor, should come to the conclusion that the clinical trial is inappropriate for me because of transportation. And I say that as a clinical trialist. I've written a number of clinical trials over the years. And one of my concerns is people think clinical trials are a lot more than they actually are. They are rarely the home run or even the base hit that a patient with metastatic disease is looking for. That's another issue we have to deal with in our world where we're worried about people not knowing the truth.
Absolutely. But I would say it's not about necessarily social, people are going to have day-to-day challenges with care. That's a whole separate issue. That's not that I believe
Right.
that Ricky was referring to. We're talking about people making decisions about a person's care, whether it's ageism, racism, making assumptions about that person as to what treatment they should receive. That should be shut down.
Yeah.
No,
That's
I
what we're
agree
referring
with
to.
you. I
Completely
started
agree,
out
yeah.
by saying that Ricky, that the doctor really should talk to the patient. And I saw light in the fact that the doctor was concerned about the patient, because very frequently I don't even see that.
Yeah. And that's horrific. But as Jamil said, for any physician to be so paternalistic that they just assume that a Black patient is not interested in the clinical trial, or that their trust will be mitigated by discussion of a clinical trial, that really is a practice that needs to be condemned. It is our obligation as physicians and as clinical trialists to take the time to make sure that all of our patients understand all of their options, which should include clinical trials. And actually, you can make the argument that clinical trial participation is even more relevant for an individual of color, because the rigor, the regulation of a clinical trial should dispel opportunities for discriminatory practices in the care that's delivered to that patient. So I would actually argue that clinical trials are even more important for individuals of color who are at risk for biases in the healthcare delivery system. And it's our obligation as clinical trialists to make sure that those transportation hurdles are somehow addressed, and to make sure that clinical trials are feasible for the majority of our patients, regardless of their affluence or lack thereof.
Yeah, I would add also that, when you look at triple negative breast cancer, and maybe I'm, partial to that because that's what I had, we don't have a lot of options. And so when I talk to a triple negative metastatic patient, I always say, ask for a trial, or even early stage. Now we have some great drugs that have been approved for metastatic triple negative, but not that are in clinical trial for early stage. And I will always say, ask your doctor for this drug, and go request a clinical trial, because we know that the data has been proven for metastatic and it's very good, and you may have a better chance to be in a trial for these drugs. And so I really encourage those trial conversations with your doctor to make a good decision for yourself, because our risk is so high. We get it twice,
and if you're not
at twice the rate.
Yeah.
If I could just put an ad in here, by the way, Ms. Fairley, you and I live in a state where if a doctor offers transportation or even pays for parking for someone who's in a clinical trial, it has been considered an inducement.
coercion.
Yeah. You can't give, Lisa, I heard you when you said provide transportation. I can't do that. I wish
I didn't say
There's
provide
community organizations that you can connect patients to.
Yeah. And
Address it. You can't address it.
Not so high for multiple visits. We can address those things in creative ways that make the trials accessible for everybody. There are ways to do that. I just to add, Ricky, everything you said was so right on point. Even if a patient is not a candidate for a clinical trial, however, there are other ways to contribute to important research, simply by agreeing to contribute to a biorepository program,
Right,
where we can learn more about the cancers of diverse patients. That is extremely important and meaningful.
Yeah. Now, let me just give an ad for clinical trials. I do much of my work is how a certain proportion of people don't get the drugs, or don't get the drugs dosed when we're talking about chemotherapy, or certain surgeons have lots of positive margins after they do surgery and others don't. Doctors this has been shown for 30 years. Doctors who put 3% of their patients on clinical trials take better care of the other 97% of their patients compared to the practice patterns of doctors who don't put patients on clinical trials. Yeah. So I encourage people, if there's a clinical trial available and you want to participate in it, If there's no clinical trial available for you, still try to get a doctor who participates in clinical trials. The chances you're going to get better care are higher.
Wow.
Dr. Lisa, what do you think about that?
Powerful statement. And as somebody that's a strong advocate of clinical trials, I'm right on, right on. One thing I will add, however, is that a lot of our communities of color receive their healthcare in safety net institutions, and these safety net public hospitals, they do the very best they can, but unfortunately do not have the resources to be able to support clinical trial offerings. Yeah. And again, that's on us as, guardians of the healthcare system. We need to fix that problem. But I wouldn't want to cast aspersions on the wonderful intentions and care that are delivered by those physicians that dedicate themselves to safety net care.
That's a really good point, Lisa, and that goes back to Jamil's point earlier. I've come to believe that our system of multiple different ways of paying for healthcare is in itself a form of racism. It's an institutional racism. I mentioned that the Blacks in California treated for colorectal cancer end up in overcrowded hospitals. That's overwhelmingly because they either don't have insurance or they have Medicaid, which doesn't pay well. And the hospitals where the pathologists only have 1 or 2 patients to deal with per day, those hospitals don't take Medicaid. They take the high-end private insurances. And so I really do think we need to figure out how everybody gets one standard of care. And I do believe, and it took me a long time to come around to this, it means one standard of payment as well.
Yeah.
Jamil, you are in the trenches every day helping metastatic patients. And so you're seeing this. And I think that, what's making you successful is you are like dealing with, it's like a one-to-one case by case, patient by patient, person by person, where you go in and basically help them manage their care. And we need to scale you. So how can we do that? You know what I mean? I think that you have now developed this model for, somebody calls you and they need help and you're on it.
Right.
And you're on it like white on rice.
And the reason is because there's value in patient navigation, right? But we know what quality care is. That's what I keep saying. I think sometimes it can just be so muddy. And I think that it then becomes where people are like, oh, I washed my hands of it. It's insurmountable. But actually, it's not. We know what comprehensive care is. We have the roadmap. We have this quality standards of care. This is what our health systems are supposed to be implementing and providing to patients. And when that's not the case, when we see that variation between what white patients are receiving and what Black patients are receiving, we can quantify that and say, okay, is that structural? Is that procedural? Is it due to some of the, payment challenges and things like that? Or the leading evidence shows that a lot of times it is due to bias and it's due to racism. And so how do you, knowing we're dealing with people the same way we deal with racism in education, the same way we deal with racism in society and law enforcement, and we have accountability there, you have to have checks and balances in these settings. So that way a person just doesn't have the autonomy to cause harm. And I think also it's acknowledging that racism in the healthcare setting causes harm. It's going to result in poorer outcomes in Black people in their care and in, just how they're going to fare. And the earlier that we can have them on that continuum and on that trajectory to get standard quality care, that really is the key, where we see that when that racism is, checked, where it's not going to be able to cause harm, and that there's other checks and balances in place and visibility and accountability, we then see that the outcomes of Black people mirror the outcomes of the white people. And the thing that's interesting, though, is that I think people think, oh, well, it's just, the Southern states, or it's just the rural, or it's just the community. We see the same level of racism in the Northeast, affluent NCI centers as well. So I think making sure that, because we can deal with the barriers and the access to care and the challenges and the insurance issues and financial toxicity. That's all part of comprehensive care. We know what that roadmap is. We know what that should look like. So making sure that that same all hands on deck mentality when it's a white life has to be applied when it's a Black life. And I think when you have it as simple as that, that's when you see that outcomes improve.
Right. Right. Dr. Lisa, you're nodding your head.
Yeah, it's so true. So much of healthcare disparities, including breast cancer disparities, other cancer disparities, can be fixed by correcting the systemic racism that exists in our healthcare delivery system. I personally, as I mentioned before, still believe that research involving the genetics of ancestors
Absolutely.
Yes.
also needs to be addressed. But that's all part of access to care as well.
It is.
Access to research,
It is.
having more diverse researchers that are designing these studies and implementing programs to address it. It's all part of the same picture.
Right. We haven't really talked about pharma yet, but, I really believe that the pharmaceutical industry needs to really step in on
Yes.
designing the right kinds of clinical trials. So
Yes.
clearly there's a recruiting issue for getting Black participants in trials, right?
And I just want to add also, not just having Black participation, because it's not enough to just have a large population of Black people in a clinical trial, but to make sure that it's inclusive and equitable and that, they're going to be treated equitably in that clinical trial as well. Because I do see clinical trials where, there's so many Black patients and participants, but they're not receiving that same care coordination as the white patients that are involved in that clinical trial. So that's important as well, not just diverse, but equitable as well.
Right. And I read a study actually this morning for a hospital in Pennsylvania where they had great success getting Black participants. You know the story. And it was really because they were in the churches, in the community centers, in the elementary schools. They were in the community in aggressive ways, assertive ways to recruit the patients. But I want to see more clinical trials with drugs that are currently on the market. Do a clinical trial with just Black women and see how your drug fares with Black women. And I think that's what I'm kind of challenging pharma with, because I want to know how effective is your drug for our bodies?
I would disagree with that, Ms. Fairley. The big issue for Black women in the United States is they don't get the drug. It's not that the drug doesn't work in Blacks. The big issue and the big reason for Black disparities is the failure of Blacks to get current treatments. Now, it's fine to do large clinical trials, have inclusion of Blacks, whites, others, and look at the difference there. But the big issue, the big reason why we have such a problem in the United States is Blacks not getting treatments that we already know about.
But respectfully, I would say just because there's this problem over here doesn't mean that there's not something that should be explored over here. So I do see that they do have clinical trials that identify a specific drug and how it behaves in Black women in Europe and Africa. So why not also here? Because we understand that even if we know that cancer behaves differently in Black people, we also know that we respond differently to different treatments. It would just give us better insights. Yes, making sure that they have access to that drug, but knowing also how we're going to respond to it as well.
Are you arguing that Black women in Massachusetts have a different biology from Black women in Georgia?
No, I'm not talking about state by state, but those type of insights are really going to be helpful.
Much lower death rate than Black women in Georgia.
But frankly, Dr. Raleigh, I don't think
those
we
are
have
other
enough
issues,
science
and I
to
think
know.
again that muddies
I don't think
the
we have
water.
enough science to know. I don't think we have enough science to know. We haven't really done the studies. So I'm going to take some questions from our audience. And the first one's for you, Dr. Lisa. How does and this came in when you were speaking earlier about your work. So how does your hospital leadership respond to your awesome initiatives that you're doing? Are you getting support from your system?
We always need more support for disparities and outreach, health equity research. Always more support. I do feel very fortunate that my healthcare system is very enthusiastic about our research, but I'm not going to kid you. We are always in search of more support. Doing disparities
Right.
research, especially with the underserved communities and international communities in low and middle income countries, very costly, and it's hard. So I dip into my own pockets. I have for many, many years, and I will
I
continue.
know you do. I know you do.
Investment, but always looking for more support. And it's tough, but we got to keep at it. We do have to keep at it.
Yeah, we thank you for what you do, and we know you're putting all of your passion and purpose into this work. Another question: can the doctors talk about how patient advocacy organizations like mine, like Jamil's, especially the smaller ones, and we're trying to grow, effectively partner with hospitals and maybe recommend? Because I get calls every day. The doctor said XYZ, I should do this treatment, I should do this. But Ricky, what do you think? Because they want to hear it from a breastie. And I'm sure, Jamil, we talk about this all the time, that you get the same thing, that they want to hear someone who's had the experience. And I match them with someone. If I haven't had it, I'll find another breastie, because the voice of trust is with us. It's a club that you don't want to be in, but once you're in it, that we have unconditional love, and the trust is immeasurable. So I think we provide value, but I'm not sure that how can we even help doctors know about us and help their patients to reach out?
That was a question to the doctors, huh?
Yeah, to the doctors.
Well, I'll tell you, I am a big advocate for Project LEAD, which is from the National Breast Cancer Coalition, which is a sort of a boot camp for advocates.
And the graduate.
Yeah.
Yeah, boot
Yes,
camp.
you've got a graduate. Yep.
Go to learn about the principles of treatment of cancer, as well as the principles of science and how clinical trials are applied. And Project LEAD graduates end up on review committees for research grants from the NIH and Department of Defense and other places. And I wholeheartedly endorse going through it. I've taught in the course over the years, and it's wonderful.
Yeah, I agree. There are opportunities out there. We need more, but reaching out to wonderful advocates like you, Ricky, and you, Jamil, that's key, because you guys are always chaperoning, and grooming the advocates that can serve the public health and address disparities in the future and our patients here and now. So that's one huge thing. Most disparities researchers have research portfolios that will benefit voice of advocates in the design of studies. There are fundraising organizations that have training programs for advocates, like Komen has their Science and Advocates program. The Sisters Network trained advocates to work with researchers in the design of studies. There are programs out there.
That's great. And I know social workers, which is another question, kind of play a really helpful role in a lot of nurse navigators and social workers in kind of directing patients to resources that could be in the community.
Social work really underappreciated.
Yeah, totally underappreciated, underpaid, right? So I recently did a research study. I'm a marketing person. I'm not a doctor. I'm not a scientist, but I spent a lot of years convincing consumers to buy products they probably don't need. So I'm trying to, to convert that to healthcare. But I did a study on kind of the messaging around how Black women are spoken to about clinical trials. And what I identified was that a lot, and these are among breast cancer patients, metastatic, really all stages, and family members, that one barrier, a huge barrier, is that they think they're going to get the sugar pill and die. And when I heard that, I wanted to shoot myself in the head, because I know that we need to educate a lot about kind of what is standard of care, how does a clinical trial really work? But when I heard about the sugar pill, we still haven't overcome that. And I heard it from breasties, which is frightening, and they're passing bad information to other breasties. So we really have to fix that, because they're a voice of trust, the voice of trust. So I think that we have a lot of work to do to get people to understand that there is standard of care. My hope is that when I spoke to them, and on a scale of 1 to 5, 1 meaning I'll never do a trial, to 5 meaning sign me up, I could get them to a 4 or a 5 with 5 minutes of education, that defining standard of care, or stating that you'll get more comprehensive care and closer watching over you. That guess what? Advil was in a clinical trial, the drugs that you take that are over the counter. So, and frankly, as a breast cancer patient, whenever you put a drug into your body, you're on a personal clinical trial. I had no idea that THC was going to work for me, right? And Jamil's on, doing drugs now that she's just praying that they work for her. So when you kind of break it down to them, then they instantly with education, become convinced that it's a good thing to do. So how can we do more of that? How can we help people understand it better? And, you guys are in it. So how can we educate better? And to me, it's a marketing challenge. It's a messaging challenge. And that's what I'm kind of tackling right now.
What I encourage all patients to do is try to learn about their disease. Go to good places on the web. There are reputable places like the NCI, the American Cancer Society, and others. Try to learn about their disease and try to have good conversation with their doctors about the disease. Because the statistic that bothers me more than anything else is when we look at breast cancer patients, especially, it's been done better in breast than any other area. A third to 40% of Black women, and about 20 to 25% of white women with breast cancer, when you look at how they have been treated, there is something in their treatment that experts would disagree with. And it's going to be dosing of the drugs or how many lymph nodes were looked at by pathologists or something like that. Think of it, at least a third of all Black women who are treated for breast cancer have treatment that I, as an expert, would say had a flaw in it. That's a real problem.
It's a problem. That's a problem. So we have about 1 minute, and I would love to hear from Jamil. You got 20 seconds. Dr. Lisa, you got 20 seconds. What are your closing thoughts? And where's the hope? Where are the possibilities?
I'm sorry. Go ahead.
Go ahead.
No, I was just going to say, yes, there's a ton of different things and practicality that we can apply, but simplistically, deal with the racism in the care setting. Make sure that Black people get standard of care, the same care that white people get, Black people should get too. Make sure that there's that visibility and accountability where people who are HCPs can not just cause harm and have the autonomy to just do that and provide substandard care. So deal with that, and we'll really see a lot of these disparities disappear. And the takeaway is, you can reach out to community organizations like ours to increase capacity for oncology support teams, and also educate oncology teams about the impact of racism and bias and how it does cause harm and result in substandard care.
Great. And to Dr. Brawley's point, get the best care. I always say, give me the care that you give your mom or your sister.
Right.
Dr. Lisa?
Well, in this moment of time, I would say my key messages are: come back to catch up with your routine health care, get that screening mammogram, get that checkup, get out, exercise now, and try to address the obesity epidemic that we have and that affects our cancer burden. And if you are diagnosed with breast cancer, do whatever you can to get involved in the clinical trial. And if not, make sure, as Dr. Brawley said, that you're in the best quality facility with doctors that you trust.
Yeah. You guys are awesome. I thank you so much. I hope you guys have had as much fun as I had. And, be blessed. Everybody get screened for all cancers and take care. And now we're going to turn it over to Dr. Vanessa Weaver. Thank you.